All right, let's dive in, and our other participants can join us as they arrive. Good afternoon, wherever you may be joining us from. My name is Grace Rubenstein. I'm the editorial and communications director at Health Begins, and we're so pleased to have you today for this webinar on about as timely a topic as we could have right now. This is focused on hospital-driven models for food as medicine, for high-impact food as medicine. And just before we dive in, if I could have the next slide, please. Thank you. I just want to give you a few notes about how this is going to run. So this webinar is being recorded, and you all will receive by email when it's done a copy of the slides that you'll see today, as well as the recording itself. So no need to jot down notes unless you are driven to do so. Your lines are all on mute during the webinar, but we really want this to be a conversation and an interactive discussion. So if you have a question for us, the place for that is the chat, which you will see in the icons at the bottom of your screen. We always have a pretty lively conversation there, and we watch it throughout the webinar for questions. So anytime you have a question, you can go ahead and drop it in there. We'll be watching, and we'll be saving the questions and answering as many of them as we can at the end of the presentation. In fact, we're going to just give it a little trial run right now and get it started. If you can drop your name and organization and where you're joining us from today into the chat, we'd love to see who's in the room. Here's mine, for example. I see some of our fellow Health Begins staffers on the line. I see Boston, Houston, Florida, Chicago, Philadelphia, Indianapolis, Atlanta. This is wonderful. West Virginia, Michigan, Oregon, Washington, Providence. I see hospitals, I see public health, New Mexico. Wonderful. It's so great to have such a diverse set of folks engaging in this really important topic today. So this is a 1-hour presentation. It'll be a presentation from our fantastic panelists and then a Q&A based on the questions that you send us. We ask all of you to please bring respect, curiosity, and joy into this conversation. You are absolutely welcome to share resources in our chat, things that may be helpful to other people, but we ask that you do not share any promotions there. So with that, let's take a look at our objectives. If I could have the next slide. So our goal is that by the end of this hour, you will all be able to explain why it is within hospitals' capacity and interest to invest in food as medicine, to identify existing finance mechanisms and policy structures that can support those investments, and to understand how to leverage food as medicine to address both food insecurity and to improve clinical outcomes. That's what we're after today. Next slide. And now I get the honor of introducing our fantastic presenters. We have Lauren Espy, the Director of Equity and Community Programs at MLK Community Healthcare in Los Angeles. We have Maria Sonsoles de la Cruz, Director of Care Integration at Harris Health in Houston. And Maxfield Kaniger, the CEO of Canby's Markets. Each one is going to share with you a really different and effective approach to this problem that we are all tackling. Next. And with that, I get to hand the reins over to the fantastic Catherine Jantz, my colleague and consulting director at Health Begins, and your host for today. Catherine.
Hi, everyone. It's so nice to see so many familiar names and meet those of you who I haven't met before. My name is Catherine Jantz. I'm the consulting director here at Health Begins, and I'm a public health social worker by training. Next slide, please. So Health Begins is a consultancy focused on helping Medicaid serving systems move upstream and address health equity. Next slide. Our work is rooted in a few key observations. And the first is that health and social inequities are experienced as harm. And this is no more clear than when we think about food disparities and access, as well as the resulting disparities in diet-related conditions. Those disparities in diet-related conditions are a direct result of social arrangements, including structural racism, that result in differences in economic security across families in the United States. In order for us to actually achieve equity, we need to not just remove those structural barriers to economic security, but we also need to create the space and resources for healing. So part of the reason I get so incredibly excited to join calls about food as medicine and to be doing food as medicine work is that food is critical for healing. It's not just the fuel our body needs to heal, but it's also joy, connection, culture, community, and all of the things that we need to recover from the trauma we have experienced. We experience harm in communities, in homes, and so the solution for that harm has to be similarly localized. A lot of the Health Begins webinars recently have been about big conceptual or strategic threats. And so for those of you who are frequent attendees of our webinars, this webinar is going to be a little bit different. We wanted you to leave this webinar with some tactical ideas for what you can do in your community to create the resources that your community members need for healing. And this work is incredibly hard. I don't know about all of you, but I often feel like it's one step forward, two steps back. And some years it's one step forward, three steps back. And we need the support and solidarity of one another. I'm so excited that you all are joining today and hope that in chatting in the chat and connecting with one another, you can find the next hour as a moment of solidarity and support for you. So why don't people eat healthy? So this is a slide that was shared by Dariush Muzaffarian at the most recent Food as Medicine Summit in Boston. It hasn't quite been published yet. And what it shows is that there's a number of reasons why people don't eat healthy. But for people who are food and nutrition insecure, by far the biggest reason is cost. And even for people who do not have food or nutrition insecurity, cost is the second most common reason, and it affects over 50% of people who are neither food or nutrition insecurity. Next slide. So in the face of this breadth and depth of need to change how we eat, healthcare has been doing a lot of work to think about what is needed to improve people's diets. And this pyramid represents one framework for how healthcare might engage in what is increasingly being called food as medicine. There's a lot of different versions of this pyramid. This is the one that was published in Nature and was produced by the team at Chilpy and Tufts. And it shows interventions that are more clinically focused at the top, so medically tailored meals and medically tailored food programs, and those that are more focused on prevention and promoting wellness at the bottom. And that includes things like population level food policies like nutrition labeling, as well as government nutrition security programs like SNAP. What you're going to hear from panelists later today is a range of ways that healthcare is thinking about its role across this entire spectrum. We have a lot of work to do to continue to evaluate and think about how to fill the gaps in our communities. And those gaps are ever shifting. And so I invite all of you, as you listen to the panels, to really think about what are the opportunities? How can we all come together, not just hospitals, but all of the other actors in this ecosystem to really support access to healthy diets that we need to be healthy? Next slide. So you're going to hear about a few of these ideas today, but I wanted to just give you a list of ways that hospitals can address food needs. So the first is in the delivery of care. So through the routine delivery of clinical care, hospitals have an opportunity to screen for food and nutrition insecurity and refer to community resources, to provide care coordination resources like social workers or community health workers or care coordinators who can help people overcome barriers to accessing those resources, whether that be transportation or needing help completing an application for SNAP and WIC. Those activities have an opportunity to be built into value-based care models where payment is made based on outcomes and where services are bundled, and there's more flexibility to engage in activities that support prevention and whole person care. At a systems level, nonprofit hospitals do routine community health needs assessments. Many community health needs assessments already mention food as a top priority for health in communities. These community health needs assessments are an opportunity for hospitals to create dialogue in their communities and really raise awareness about key issues. Nonprofit hospitals then have an opportunity to use community benefit funds or a percentage of funds that they're required to reinvest in their community to support the food needs of their community members. In addition, hospitals are big employers. In some rural communities, they may be the biggest employer. And what we've learned through a number of evaluations is that hospital workers are equally prone to experiencing food insecurity. And so there's an opportunity for hospitals and other healthcare employers to think about how to ensure the food security of their employees. And finally, hospitals are large purchasers of food. There's an opportunity to think about how that purchasing can really strengthen the local food ecosystem and can promote the consumption of healthy foods. And finally, at a community level, hospitals are large anchor institutions that have an opportunity to partner or lead local food or food and medicine collaboratives and to use their infrastructure, including personnel, physical infrastructure, communication channels, and their political power to advocate for change, to host local farmers markets, to staff food as medicine or food insecurity interventions, and to raise awareness about critical needs and solutions for those needs. Next slide. So I'm so excited to have all of you joining today, and I want to also invite you to an ongoing conversation that Health Begins is co-hosting with Share Our Strength, called the Medicaid Food Security Network. Through the Medicaid Food Security Network, we are seeking to improve the food security of children and families enrolled in Medicaid by promoting the connection to SNAP and WIC and other food resources. Our next quarterly meeting is on November 20th, and Julian, the co-lead on this project from Share Strength, I know is on this call, and would love to talk to any and all of you in the chat, and would love to have any of you and all of you join us in that conversation on an ongoing basis. And with that, I think I'm handing it over to Maria.
Hi, everyone. Thank you for that. I'm Maria de la Cruz, Director of Care Integration at Harris Health, and I'm so honored to be here to share how we've embedded food as medicine into our care model. Next slide. So Harris Health, we were established in 1966 as the public safety net healthcare provider for Harris County, Texas, the third largest county in the United States. We serve a diverse population focusing on low-income, uninsured, and underinsured residents. Our system includes 2 acute care hospitals, a level 1, level 3 trauma centers, 4 community health centers, and services spanning wellness, disease management, population health, and correctional health care. Next slide. Now, we began screening for food insecurity in 2017 in our ambulatory care centers. At that time, we were seeing that 1 in 4 of our patients were screening positive for food insecurity. Today, we screen for food insecurity and other social needs all across our ambulatory sites, our hospitals, and through self-screening on our My Health Patient portal. We use a validated 2-question hunger vital sign tools to determine food insecurity. When a patient screens positive for food insecurity, we refer them to our partner, the Houston Food Bank, CAP Resource Navigator program. These individuals help eligible patients apply for SNAP, so food stamps, Medicaid, and Medicare. They also help them locate nearby food pantries. Next slide. Diabetes is one of our top ambulatory diagnoses and has a strong connection to nutrition. For patients with food insecurity and an A1C of 7% or higher, so they have diabetes, we enroll them in our food prescription program. These patients receive up to 30 pounds of fresh produce and healthy pantry items per each visit, up to 18 visits. At each visit, it includes support from a community health worker who's trained in motivational interviewing and basic nutrition education. During that time, the CHW will coordinate the care of the patient. So they're ensuring the patients are seeing their primary care provider on a regular basis, that they're meeting with a dietitian about 2 to 3 times throughout the 18 visits. That dietitian focuses on how the patient can prepare and enjoy the food they receive. Because this work isn't just about food access, it's about actually eating the food. It's not nutrition if you're not eating it. Our registered dietitian team also lead culinary medicine classes, where they teach patients how to cook culturally relevant meals on a budget for their families. These meals are designed to be healthy, tasty, and practical, and we hear amazing, beautiful stories from our patients. One patient recently shared with me that it was the first time he was eating a tomato. Another one said that he always thought cabbage was gross until he made the cabbage slaw recipe and realized cooking could be fun, easy, and healthy cooking can actually taste good. Patients also meet with a nurse patient educator about 2 to 3 times to learn about managing their chronic disease. So things like medication adherence, food care, and other essentials. The community health worker ensures that the patient is staying connected to community resources and learning how to shop on a budget, read nutrition labels, and make informed choices. Now, we're super proud of our food pharmacy model, which began in 2019 through a partnership with the Houston Food Bank as well as UT Health School of Public Health. Our first co-located food pantry or food pharmacy was placed at the Strawberry Health Center in Pasadena. Since then, we've expanded to 7 locations. Now, not all of our health center sites and hospital sites could afford the space for a co-located pantry. So again, we partner with the Houston Food Bank and their Food for Change pantries to develop our community redemption model. In 2020, we started our first partnership with Baytown Hearts and Hands, a trusted nonprofit with the Food for Change market. We were able to place one of our community health workers at their site to support our patients. The process is the same for the patients. They're screened for food insecurity at their yearly visit or the first time that they come to their location. They're referred over to the community health worker. The difference is that they're picking up their food at that community site. This model strengthens community ties and allows us to focus on clinical care while our partner provides food access. And we're super excited. This November, we're launching food lockers at 2 locations. These climate control lockers will allow patients to redeem food via an app, offering flexibility and extended access. The CHW support and care coordination will remain the same, but follow-ups will be done virtually. Next slide. We track outcomes through our food prescription scorecard. Using our electronic medical record, we monitor changes in fruit and vegetable consumptions, patients' A1C levels, and program retention. We also measure patient and provider satisfaction. Since the program began, we've consistently seen a 1 percentage point drop in A1C for patients who start at the program with a baseline of 7%. For those that started our program with an A1C of 9% or higher, we're actually seeing a 2 percentage point drop. Our providers will tell you that that means fewer medication. Our patients will tell you they feel more active, less foggy, and they're able to play with their kids and their grandkids, and they'll say things like, "I've lost some weight because of y'all." Next slide. As for funding our programs, our first food pharmacy was seeded by what is now called Anthem, along with the Houston Food Bank, which saw the potential to move beyond food distribution and into improving health outcomes. We've grown thanks to the commitment of our board, executive leadership, and expansion funding from ARPA, so the American Rescue Plan Act, and Cigna. ARPA helped us expand to 7 food pharmacy sites and 3 community redemption locations in the last year. The funding supported pantry build-outs and initial staffing. Cigna is sponsoring the purchase of the 2 food lockers. Staffing is funded by Harris Health and typically includes 2 community health workers per food pharmacy site, 1 per community redemption location, and half of that of FTE CHW for a food locker site. About 85% of the food we distribute comes from the Houston Food Bank, so this is at no charge to us and or the patient. To ensure variety and meet patients' preferences, we do supplement with additional food purchases. And we use funds supported by organizations like HEB, Port Houston, through employee giving campaigns, and fundraising efforts led by our Harris Health Foundation and development teams. We believe food as medicine is not just a concept, it's a commitment. It's about meeting patients where they are, addressing their root cause, and building sustainable partnerships that improve health and dignity. Thank you all so much for your time, and I look forward to your questions at the end. Next slide.
All right, I think it's my turn to talk a little bit now. So my name is Max Field Caniger. I'm the founder and CEO of an organization in Kansas City, Missouri called Canby's Markets, where we're more on the access side of things. So our mission is to build a more equitable food system by turning food loss into food access. In so many ways, we survive on partnerships, and we work with and around hospital groups. We work with small corner convenience stores. We work with other nonprofits to deliver a variety of services to make that real. One I'm going to, I think, spend the most time talking about today, if you go to the next slide, please, is our Healthy Corner Store model. So this model is where we provide the equipment that you see in the picture here to now over 100 small businesses all across Kansas City, Missouri, where then we restock these coolers 5 days a week with fresh, healthy, and affordable food. So when we talk about access at Canby's, we talk about it not just in proximity, but in affordability. Like we said earlier on this call, cost is huge for these families. And so we want to make sure the produce that people have access to is as affordable as possible. And that's where the food in our coolers is typically about 20 to 25% below even Aldi and Walmart pricing. but then it could be made even more affordable through some of the partnership programs that we've now launched with different hospitals. Go to the next slide, please. These food as medicine kind of voucher programs have become a really exciting part of how we can make access more of a reality across Kansas City. So we started with two different hospital groups. They are enrolling patients into these programs for a variety of reasons. Each hospital has their own qualifications on what would allow somebody access into the program. Once they are enrolled in the program, we find out through the Find Help portal. And then we get in touch with those individuals and get them their weekly vouchers. They're between $10 and $20, depending on, again, the hospital program that they're enrolled in. But those vouchers they're able to redeem at a growing number of our existing convenience store network. Right now, we're seeing about a 60% redemption rate on these paper vouchers, and we're consistently looking at different ways to make this more accessible and easier for each of the individuals and families that are enrolled in these programs. Because really for us, it's all about partnership. It's all about how can we use this existing network where families aren't having to rely on behavior change to find access to fresh food. These are stores in their communities that they're used to shopping at that are close by, so that it's just a short walk to the end of the block, and we can make it as easy as possible for them to choose to eat healthy food. If you go to the next slide, I can show you a little bit about what. So this is what the low income, low access areas looked like prior to Canby starting back in 2015. Unfortunately, the two grocery stores that opened since then have also closed. But if you go to the next slide, you can see this is our network of corner and convenience stores that we're working with kind of all across the Kansas City area. And so even stores that haven't officially been enrolled in the Canby's voucher program with the hospitals have enough trust and connection and relationship with us that they when they see a Canby's voucher show up, they take it, they provide food to the individual or family that's there to pick it up, and then we figure it out later. And it's been a really, really wonderful experience to see how working together with hospitals, with the small business owners, with community-based organizations can really lead to a seamless program for the families and individuals that we exist to serve. And so I appreciate this opportunity. If you go to the next slide, here are just some ways to find out more about us, but I look forward to the conversation later.
Thank you. And before I pass the baton to Lauren, just want to reiterate, love the questions coming in the chat. We're capturing them all. We're putting them in a list. Keep sending us questions, and speakers will respond if they can. Otherwise, I'll put them on the discussion for the end of the meeting. It's great to see your interest. So with that, I'm going to hand the conversation over to Lauren.
Thank you, Catherine. Hi, everyone. I'm Lauren Espy, and I'm the Director of Equity and Community Programs at MLK Community Healthcare. So I'll be talking about our Recipe for Health program. And I wanted to give a quick background first. The MLK Community Healthcare, the hospital, we sit in South Los Angeles in California, and that's one of the most vulnerable communities in LA County with limited healthcare access for our community members, a shortage of physicians, about 1,500 actually providers in our area. It's a shortage of that. And there's a high prevalence of chronic disease in general. And our community also faces a food desert condition. So we have abundant fast food outlets, and we're in limited access to affordable, healthy food options. Many of our participants and patients also face chronic conditions, as I mentioned, diabetes, heart disease, obesity, and food insecurity. And before 2019, we didn't have a set nutrition program that was linked to primary care or the hospital. So we did a formal review. We looked at one of our outpatient clinic sites, which is also called the MLK Community Medical Group, as you see here on the slide. And we identified over 400 patients that could benefit from a program such as this that had those diet-related conditions, as I mentioned. So we developed this program called Recipe for Health. And it provides patients with access to healthy foods as part of their chronic disease management. It integrates food insecurity screening into their primary care visits when they come to our clinic, and it links patients to community resources or nutrition education. And in addition, we're tracking their health outcomes along the way and really providing that support that's needed. Next slide, please. So how this program works. So the patient comes to our doctor at the medical group, as I mentioned, and the doctor will determine if they are eligible for the program. And the doctor then sends them to our care coordinator, who then does a food screening, a food assessment with them. And there's a scoring sheet that determines whether they will be eligible for the program. So with that, the patient then, once they're enrolled in the program, they receive what's called food vouchers, and they look like a prescription. And one voucher is good for 1 week's worth of produce. So they receive 4 food vouchers, which is good for the whole month for the patient. And they call, excuse me, they call our hospital. And I'll talk about our partner in just a bit, but they call our hospital to pick up their produce package from the MLK Community Hospital. And they have to make sure to bring their food voucher with them in exchange for a food package. And that's good for 1 week's worth of produce, as I mentioned. And it doesn't just stop there. They have to make sure that they attend some type of education wellness class. With us, we actually have a cooking class that we started in 2023. Prior to that, we actually had a program where we connected patients with a cooking class. So we started this program in order for the patients to get better insight on how to prepare, how to, really support themselves when they have this produce that we provide to them. And then they have to make sure to check in with their doctor on a bi-monthly basis. Next slide, please. Okay, so our program partner. We have some key qualifiers on what we determined as our program food partner for doing this program. And one of the main things I thought about was over time, when we have the volume of patients grow in our program, who is going to be that partner that's going to provide seamless communication, making sure they track all of the produce that they provide to our patients because they're providing them a customized produce package based on their diet-related conditions, easy implementation, it's cost effective, and so forth, everything down this list. And Sodexo is our partner because actually they are also our hospital's food vendor. Sodexo actually, in our cafeteria, we have a healthy food choices all throughout our hospital, but also in the cafeteria. So a lot of our community members come to the cafeteria to receive this affordable, healthy food. So it was kind of a no-brainer for us to decide on them as a partner, and they've been amazing. As I mentioned, our program started in 2019. We had over 200 patients on the program. We now have about 500 patients on the program. Easy implementation. There was no, issues with that growth in the volume. So it made it a no-brainer, as I mentioned to us. Next slide, please. So program duration. How long can the patients be on the program? Truthfully, the patients can be on the program anywhere from 1 to 3 years. We really put it in the patient's hands that they know how to build their own healthy food habits. So we allow them to, take into account what they want to decide on that. There's a pre-screening that is done. There's reassessments that are done as you see here in the months 3, 6, 9, and 12 within the year. And then we do a post-assessment to really ensure that the program is not only beneficial to them, but we also want to make sure it's beneficial to their family as well, because we see patients with households up to 5, sometimes 7 in their household. So we want to make sure that it's an overall great program for them. And some of the outcomes that we see are, their hemoglobin A1C levels and their blood pressures have been improved. Really, 85% actually across the program have seen those improved numbers, and we've been seeing 11% of their rates that are being maintained as well. And additionally, we look at emergency room utilization. So we've been seeing a reduction for our patients going to our emergency room at the hospital. And we've been seeing an improvement on their no-show rates or their doctor's visits. So they're going to their doctor's visits, not just for the program, but also for their other needs as well. Next slide, please. Funding, how does this look for us? Right now, we actually have about 70% of our funding coming from our hospital budget, and then we have philanthropic funding as well. So we currently have a really great funding partner that's providing this for us, and we're looking at insurer funding currently, pursuing that, speaking to some health plans to ensure that we have that as well. There's always going to be challenges. And if we're looking at reduction of Medicaid cuts, Medicaid is actually a huge in our community of the patients that we see, about 80% of our population. So we're always looking at ways to make sure that we can be provided that funding. And I actually just wanted to also mention that a lot of our patients are seeing overall, since they're on the program from a year to 3 years, they're really saying that they never knew so much about the food. A lot of them are saying to tell other people to change their diet immediately, especially if they have diabetes, because they're seeing so much life changes. Um, and overall, they're really seeing an abundance of food selections that they didn't even know was possible. So if you wanted to see or learn a little bit more about our program and how this has impacted some of our patients and the way that our Sodexo Food and Nutrition Services partners have also worked with us, there's a link that is being dropped where you can watch it. We had a dream show this past year where we highlighted this program. And that is all I would like to say. Thank you so much, everyone.
Thank you all so much. So we have received a ton of questions. So I want to invite Maxfield and Maria to come back on video. So we'll start fielding the questions from all of the audience and invite everyone to continue to put your questions in the chat. So first, just want to ask you all, and you can decide who wants to answer this question. How did you make the case for doing this work with either your hospital partner or within your hospital? How did you get the necessary leadership buy-in? What were the arguments for doing it that most resonated with your leadership?
I can start. So, as I mentioned earlier, we started screening for food insecurity in 2017, and we realized quickly that we needed to do something. We also know that we are a healthcare setting and we're amazing at providing care to our patients, but we aren't the experts in food. So we try to figure out who did we need to partner with. And at that time, we also looked up what are other organizations doing, what are best practices around providing access to healthy food for individuals, supporting patients with diabetes. And we talked to organizations like Boston Medical, who all had some sort of prescription program. And through that, we were able to go and talk to our leadership and get their buy-in. And we had to have their buy-in from their beginning. And that took some time. And that's why we only started with one food pharmacy. And it took not only buy-in at the leadership level, but at the healthcare setting as well. So like the operations leadership, they had to make space for us. We had to figure out all of the regulatory environments. We had to get compliance on board, infection prevention. But after we got the first one out and we saw that we were seeing patients and that patients were accessing food and that they were getting the nutrition education, and not only that, we were seeing a drop in A1C, we were able to get everyone excited, and now everyone wants one. Everyone wants a food pharmacy everywhere, and it's been part of our journey.
Lauren or
Yes.
Maxfield, that's awesome.
Yeah, so I also wanted to jump in. Similar to Maria, we started with first looking to see what was out there. How can we maybe see if there's any other models that we can possibly try to reinvent within our just our health system and within the community. We didn't see anything typically like that out there. There are a lot of great food programs that were there, but something that would work for us. So buy-in for the leadership was actually pretty easy. We are a small nonprofit hospital, 130 bed community hospital, and innovation is one of our number one things. And so looking at this program, we got buy-in immediately from leadership and working with IT to make sure that we integrated this food screening model into our EHR, or electronic health record system, was pretty easy as well. It took a lot of work, but holding that hand, and also the buy-in from Sodexo, as mentioned, with the food and nutrition services team that we have, that was also, everyone was on board to ensure that, as mentioned, we're looking at our community that faces this so much. So we wanted to be able to provide what we can to say what we have in our mission.
That's great.
Yeah, and I guess from our end, not being at the hospital, actually, we had some wonderful partnerships with individual community health workers, some of the doctors at the hospitals that really championed for us. We were already kind of in existence doing the work that we're doing, and made some nice inroads with some of the people that are on these teams now. And I think we just kind of lobbied for support, and the hospitals dove in.
I'm going to ask you all a follow-up question, which is that you have a lot of options for partners when you develop these programs. So Maxfield, for you, how do you make the argument that they should partner with you rather than other national vendors or other vendors they could select? And Lauren and Maria, as you made your partnership decisions, what were the considerations and factors you took into account as you decided who should be your food vendor?
Yeah, I guess I can go first because that's a great question, and I guess I don't really argue for us. If the national vendors have great deals, then I want more food out for more people. I think it takes a little bit of all of us to do that, and so if there's already great relationships, I mean, we have some of those kind of relationships, and I'm happy to make connections for hospital groups. And if it works better to work with a national vendor, then we say go for it. We're here to support. In many cases, because we're able to pull in food from a variety of different places, whether it's smaller and local farms that didn't get as impacted with some of the crazy price increases throughout this year, or it's other donations, donated food that are able to supplement this. We're often able to get better food at lower prices than a traditional wholesaler might. But I'm not really fighting for it. I'm more like, what do we have? How are let's lay our cards out on the table and see how do we get food to people.
Maria and Lauren, anything to add about how you selected your partner?
For us, the first partner that we reached out to was the Houston Food Bank, which is the largest food bank in the country, and served our patients. And so that was an easy connection. They were doing the work. They were the experts in providing food and distributing food. And at that time, they were interested in not just food distribution, but how do they affect neighbors, community members' health outcomes. So it was a natural connection. And then we had already partnered with UT School of Public Health on evaluating, and we do some research projects. I see one of the questions talking about, do any of our programs focus on patients with cancer? So we do have a research project currently focusing on food as medicine and cancer. And those are all through partnerships with MD Anderson and UT School of Public Health, which are the providers of Harris Health. So Harris Health, as a safety care system, our providers are coming from the major schools in Houston, Harris County. So UT, Baylor, and MD Anderson. So it was just easy connections.
Yeah.
Similar to Maria, in terms of easy connections, as I mentioned in my presentation, that we thought about seamless communication with a partner that we've already had that can account for that scaled volume of patients. We grew quite a bit pretty quickly. And in terms of if there's any mini issues that happen to go on with a patient wanting to mention something to their doctor, it's pretty easy within our health system to reach out to them pretty quickly and get that resolved right away. So that was one of our main indicators, especially with our patients building that trust, continuing to build that trust with our healthcare system.
Yeah. Okay, on a different topic, one of the questions we have is around screening, and notes that a lot of the food insecurity screenings, people fall through the cracks. Either they screen negative, but they actually are experiencing food insecurity, or they're just using food funds that they maybe needed to use on rent or other things. And also, people have many reasons why their diet is not ideal, and it might not just be cost. And so, how are you addressing those whole pieces? And so I want to hear a little bit from all of you about, how are you thinking about identification of people to serve, and how do you make sure that people don't fall through the cracks of your program?
I guess, yeah, I can go first because we don't really have say in the screening part of it. We leave that to the hospitals. Whenever somebody is brought into the program, we don't ask a whole lot of those questions because it's not really important to us. We want people to have food, and so whatever reason the hospital has determined that they would find value in this program, we want to help. And our goal is also to continue supporting them after the voucher program would be over. So typically people are in that program for 6 months. We're hoping to help them kind of transit even after the vouchers may stop, whether it's re-enrolling them to start the program over again, or just if they're in a different phase of life and they can shop for the groceries themselves, we have options for them there.
I like that. And Lauren, your program is so long.
It is. Yes. Yes. So, for us, again, we want to make sure that we provide as much as possible for our patients, for the resources. And when we first started the program, I sat down with our social workers, and just our social services, team members, and we looked at all these different types of food insecurity screenings, and we decided this is not necessarily fitting within what we want as far as providing for our patients. So we decided to tweak the screenings a little bit, to ensure that it's not just about the access part of it, but it's about, whether they're eating enough fruits and vegetables, whether they know knowledge-wise where to get the healthy fruits and vegetables, and affordability, or are they going an entire day without eating, those types of things that we wanted to make sure to indicate those in our screenings. So for the most part, we don't really have, no matter where they are on the scale, we're still providing that prescription or that voucher to them. And if not, then we have other resources to provide to them that might be a little bit better, for either their health condition or just the whole health plan that they have with their doctor too.
And for us, we do use the 2-question questionnaire, and we train our staff to ask the questions using a laminated form. This is what we've learned to reduce some of the stigma of answering the questions head on, instead of being asked directly, have you not had access to food in the last 12 months, but really having that paper. And we've transitioned it to our patient portal, which allows the patients click yes or no. So that's the first part. And that's just the beginning stages. But there are conversations that happen via the connection to the primary care provider. And for many of our patients with an A1C of at least 9% or higher, they're referred over to the dietitian team or the nurse patient educator or even case management. Those team members can also refer over to the food prescription. So that's how we're trying to catch those that fall through the crack. But it is part of our conversation in most recent years of how do we not just focus on food insecurity, but nutrition security, and supporting patients. So we're working towards it, and we're seeing where to go next.
So I'm gonna Maxfield, did you want to respond to that, or should I? Okay, so I'm curious from all of you, maybe Maxfield, you can start with this one. If you're tracking rates of non-participation, so people who got the voucher and are not using it, and if you understand why they're not using it, what are the main barriers for people participating in your program? And we got a really specific question around, do you have any reflections on the preferences or the use of produce or grocery programs versus meals or some other food program? So yeah, what are the main barriers to using your program?
Yeah, I'll try and knock out all those questions real quickly. So for tracking, yeah, we I think I mentioned, we're averaging about a 60% redemption rate. And every single month we're checking in, not just with our team, but the different hospital groups and their teams to see what's going on. We're kind of cross-referencing. I think it's less than 5% though have ever just not used the program, like where they're given a voucher and it never really checks in. And sometimes it's because even our corner stores are a little far from them. Most of the time it actually ends up being that the person in the program ended up back in the hospital. And so they'll be off for that month because they'll be in the hospital. And so usually we're able to do a little cross-referencing there. But other barriers like should this be home delivered or whole meal? I think yes. I think again, the more ways we can get to people and address these issues, the better. I think there are absolutely people who a convenience store where you can shop and you can buy groceries that you can take home and make a meal for yourself is wonderful, but it's not a one size fits all. And I would love to expand to home delivery. At that point, I think it starts to dial a little bit more into cost. We are, delivering to a network of stores that we can get a lot of food out relatively affordably. We have done home delivered meals before, where we were delivering to about 25,000 people a month. And it was just prohibitively expensive, and it lost federal funding for that. And nobody could really pick that program back up. And so this has just been a happy medium. We're looking to add more options to what we stock in our stores. We've got eggs in there now. We're looking to add some meats and other proteins. We're looking to add dairy. We're looking to add whole meals because, like I said, when we were doing home delivered stuff, we were producing meals then, and we could do because of the volume of donated food in, we could make meals. I think our total cost was under $2 a meal for some really, really great quality meals. But those are just plans for the future. I think did that answer those?
Yeah, that answered that. Lauren, Maria, you want to add anything else about barriers you see?
We've seen
and
with
how you-
our patients, number one is transportation. So access, Harris County is huge. I'm from Jersey. I grew up in Jersey. So when I came to Houston, I didn't realize it's an hour from Houston, like anywhere in Houston. So transportation, number one. Work, right? So people are working during hours that we're open. So getting to us during working hours is hard. For our programs, we do allow for sub shoppers. So you can assign someone to go pick up your food for you and get the education via phone calls or virtual care. So those are the two main reasons or the main barriers that we face, and we're trying to see how we extend that. We also have two research projects going on right now. One is focused on patients with chronic kidney disease, and one is focused on high-risk pregnant women. And both of those research projects, we're looking to see our home delivery programs, will they support in delaying increase in CKD, so going from CKD 1.2 to 3.4, or allowing for high-risk pregnant women to have healthy pregnancies and after pregnancies. And we're trying to see the feasibility of those programs and the cost and all those things. So we're looking into those programs. But yeah, those are the two main barriers that we see. Childcare is probably the third.
Lauren, anything they missed?
No, I echo Maria on the transportation and the, picking it up during work hours. The pickup time for our patients is Monday through Friday, 9 a.m. to 5 p.m. So it could be difficult, but just like Maria said, we tell patients they can assign someone to come pick up their produce packages for them, as long as that food voucher is provided as well, and they call in to let us know. Sometimes we actually have a partnership with Uber Health. They can do it that way as well. And so pretty much that's how we get around that. And there was another question on preference of meals versus groceries. I just wanted to mention that we look at it as, I would like to do meals, but because our community is culturally diverse, we like to make sure that we can tailor certain recipes for certain cultures. So we keep that in mind as well.
Thank you. So there are a lot of questions we're getting about, how do we fund this, scale this, what's the impact of the current environment? So would just love to have each of you talk. I know most of you addressed sort of your financing model right now during your initial remarks, but just would like you to expand a little bit on, are there ways to maximize current payment pathways like principal illness navigation or community health integration codes through Medicare? Are there, how do you see the current healthcare landscape and policy landscape impacting your ability to scale? And what policy changes do you hope for? What do you need to sustain and scale your efforts? And I don't know who would like to take that one first. How can we build? How can we expand these programs?
Well, I can just go first. Just in terms of the policy, one change I think I'd like to see is the formal integration of food as medicine programs like Recipe for Health into standard clinical care workflows and reimbursement structures. Right now, these programs they're often funded, or especially with ours, by grants or pilot initiatives, but building internal policies that make food prescriptions part of the care plan, documented in the electronic health record, track through referrals, and the reimbursable when possible, I think would ensure that long-term sustainability. And I mentioned that we currently are looking at the insurers for that reimbursement part, but it's heavily funded through our hospital operating budget and a little bit of those donors for us.
I echo that, Lauren. It's exactly what we're looking into, and it's how we are currently funded, and what we're hoping policy does change to allow for us to, at least in Texas, we're looking at fee for services or using 1115 waivers and things like that to support the and continue the efforts with our food as medicine. That is where we're at right now. And then on the side, we work with our partners to determine like how can we make sure that all of our patients that are eligible get connected to things like SNAP, and how do we make sure that patients and people have access to SNAP, and then we do the same for WIC. So for our pregnant mothers or patients with kids under 5, we're connecting them to WIC services.
Anything you want to add about financing schemes?
Yeah, mine is similar, and so I guess I would just add a little bit more of that. We have more conversations like this to help begins on a national level, so we're all speaking the same language. And when we are talking to the larger systems, whether it's our politicians or elected officials, that we're having the same conversation over and over and pushing that.
I love that. And I don't know if anyone else here attended the Food as Medicine conference in Boston recently, but I was really heartened to see the number of policymakers across the aisle who presented or had videoed remarks really talking about the importance of these food as medicine type interventions. So I have hope for all of us that we can continue to build these programs. Okay, I have a tough one next. Are you all ready? So this is from Alita. I apologize if I'm mispronouncing your name, and I'm actually going to read it. Good to see the healthcare sector standing up to fill the gap in food ecosystem. Can you speak to how you're plugging in and connecting the dots and partnering with more grassroots food justice, food sovereignty, local and urban farmers, community gardens, and local public health efforts that have been around for decades that have initially been ignored? Also, are any of you framing your intervention within the context of climate and sustainability? And before I ask you to answer, I think we're all early in this journey. And so, invite both your current reflections on what you're doing, but also where you hope to go.
Yeah, so part of my role, I sit as the co-chair for Houston's Health Equity Collective, which is a coalition of organizations starting from Sustainable Planet Harvest, which focuses on farmers and like the system, to nonprofit organizations work like the Houston Food Bank is a co-chair with me, to other healthcare settings in Houston that are all working around the access to food security. And what do we do? What does that landscape look like for us? What does stigma look like around food insecurity? How do we ensure that we're all fighting the right fight and speaking the same language and talking to our policymakers? So that's part of my role here at Harris Health. and it helps us to better understand what that landscape looks like, and also be able to like connect to those resources. So that's one aspect of that. What I hope is that we continue the work that we're doing, that we learn things like how local farms and farmers can, how can we get those food to our patients or to our clients or to our neighbors, and how and what policies do we need to support to ensure that everyone has access to food and to healthy food. So that's where I'm hoping we're going, as we go through this.
I think I have that hope too, Maria. I have conversations a lot with the urban farmers in our community. I actually went to go visit one not too long ago, and learning of all the great work that they're doing and how can we integrate it so that again that it's seamless. Never want to ignore them. I completely echo that. That's something that we shouldn't do, and we should always keep our food ecosystem really close with healthcare because as this whole conversation is about food as medicine, it really does intertwine with how people's livelihoods are. So that's my hope to grow this program as far as that opportunity. And so continuing to ensure that we have those partners and that we're continuing to have those conversations and that they don't stop and that somewhere we can really say this is where it's going to impact for our community and for the patient. So right now we're trying to keep this program at a steady level to see how far we can go with it and then always welcoming in new partners as far as resources and then seeing how we can integrate it.
I do. I love all of that. And I think, I'm going to continue beating the drum of partnerships with all of this. I think that's a big part of the role we play, in that we are essentially a distribution company. We're trucks and warehouses. And I think our greatest strength is our relationship. So I mentioned, the 100 corner stores. We've got another 50 nonprofits that are picking up food from us. But we also have a network of other organizations that actually warehouse here with us, one of them being a food hub. So they're a co-op of about 200 farms all across the state of Missouri. And so when we're talking to hospital groups about, well, what do we need for this? I just was hearing about Thanksgiving and holidays are coming up. And one of the local FQHCs is wanting to do a big food giveaway, and they've got turkeys that they wanted to source. And so I've got a farm down in southeast Missouri that can source us the turkeys at a competitive rate. And so I think that's a part of it is we exist to make some of those connections. We've worked with small community gardens, and we're having conversations about how do we differentiate between gardening and farming. How, there's absolutely something cathartic about getting out in the sun and growing some tomatoes for yourself and just having a moment away for a little peace and quiet. And then there's something to be said for trying to earn a little extra money right now. And when we've talked to there was a small, it was on a 2-acre plot of land, and that it had always been kind of a community garden, but they were hoping to make a little bit more money, and they only need about $5,000 a year to run that community garden. I was like, well, I spend more than that on cucumbers. And so if you will plant in this section cucumbers, I will buy all of them. And I'm not going to give you the farmer's market price for it, but so I'm still going to encourage you to do that. But we will buy it wholesale, and I'll spend more than $5,000 on cucumbers. So just this section can now make the garden more sustainable. But it continues the conversation around how are we continuing to empower every piece of the food system and bring us all together in this.
I can't think of a more incredible note to end on. I'm so inspired by how each of your organizations and each of you is trying to figure out how to maximize your impact with the resources that you have. And I hope everyone else leaves as inspired as I'm leaving. As Maxfield said earlier in the call, this is one of those big problems that requires all of us, not just local nonprofits, not just national organizations, not just healthcare, not just, food as medicine providers. And so happy for everyone who joined today. And hope everyone leaves feeling inspired to figure out how they can do their part. With that, I'm going to pass it back to Grace.
Thank you so much, Catherine, and all of our panelists. I think we can feel how timely and important this is. And there were questions too about resources that can help folks along the way. Health Begins is going to continue sharing more of those and some best practices in the coming months. Keep an eye on your emails for that, as well as for an invitation to our next webinar coming up in just a couple of weeks on strategies to sustain health equity investments against headwinds. We have a fantastic set of panelists for that. And as far as next steps, um, we will be sending out this recording and slides to all of you. Watch your email for that. We'll include the links that we dropped in the chat as well. When you close this webinar, you're going to see a survey pop up on your screen. We really appreciate you taking just a minute to fill that out. It helps us bring you even better, more helpful webinars in the future. And finally, we consider this an ongoing conversation. So let's keep it going through Blue Sky, through LinkedIn, through the webinars to come. Thank you so much, and we hope to see you in November.